Our next speaker, Dr. Vinay Pillai, who is a senior consultant and head of cornea and refractive surgery from Giridhar Eye Institute. And he is going to talk on managing delayed post-op complications of keratoprosthesis and how the tips to retain K-Pro.
Thank you, Dr. Chitra, for this opportunity. Yes. Once again, yes, we are back to K-Pro from the other extreme of cornea. I mean, corneal disease to the extreme end. So, like any condition, it's always better to prevent complications from arising than to address it. So, and it starts right from preoperative patient selection. So, the most common K-Pros which we use now are the Boston type K-Pros and the in the dry eye, osteointerkeratoprosthesis. So in Boston type, we have to be sure the ocular surface is otherwise healthier, other than the stem cell deficiency or things like that. Normal lids, wet eye, while in dry eyes, it has to be the OKP. Intraoperatively, well, you can have things flying around, especially when you're assembling a K-Pro. When you're punching the donor cornea, if it becomes eccentric, it can have backplate protruding on one end, and when you're assembling again, you can have the backplate breaking. Now, Oro K-Pro, which is the Indian variant, we have to be careful because at times, we have an LVP variant of Oro K-Pro, which is slightly different from the Boston type of Oro K-Pro. So we are planning for Boston type, and you get an LVP K-Pro. It is very difficult to assess initially till you reach the end of the surgery, or rather when you start assembly. Then the routine problems like bleeding, expulsion of the lenses, supracortical hemorrhage, and so on. And in OKP, there are certain special things like when you're harvesting the mucosa can be damaged, or you can have a buttonhole. When you're harvesting the tooth, it can go into the antrum, causing a fistula. You can have damage to the adjacent tooth, or there might be excessive bleeding. Post-operative immediate problems can be leak, which can be perioptic or from the graft-host junction in Boston type keratoprosthesis. They can be bleeding into the anterior chamber. Intraocular pressure can be high and low, maybe because of leak or other causes. In Boston type, maintaining the BCL on the surface can be a problem if the ocular surface is not normal or ideal. Like inflammation, infections or other problems. Now, why is the delayed complication important? Because all these keratoprostheses, if I may say so, may be considered as time bombs. Okay, they can explode on your face anytime. So a high index of suspicion for problems should be there. And at each visit, we should actually actively look for problems that can arise rather than just a routine screening. Some signs that help in, predicting some problem later, like air bubble under the BCL, which can cause the desiccation of the epithelium and breakdown and further problems like infection, persistent defect, melt of the graft, and so on. So the other sign is when you're staining a Boston type keratoprosthesis, if there is pooling of the dye under the anterior plate, it shows that the graft has kind of thinned off and can result in later problems. If the optic cylinder is slightly mobile, and all these cases, whether it's an OQP, whether it's a Boston type keratoprosthesis, we should always touch the optic cylinder and see how they are, whether they are stable or if there is any mobility. Change in refraction is an indirect indicator of tilt in optic cylinder, again, because of the melt or problems in the haptic tissue, either cornea in Boston or the bone tooth complex in MOKP. Vision can drop because of various reasons. Intraocular inflammation, either sterile or infective, can be a reason, or retroprosthetic membrane can be another reason, which is quite common in Boston K-Pro, but at the same time, it is not that common in posterior keratoprosthesis. Now, graft melt is a serious issue in Boston type keratoprosthesis. It can be, as I mentioned before, BCL-related desiccation-induced melt, or because of ocular surface problems, either mechanical or immune-mediated, and then a thick RPM itself can induce melt. AS-OCT in Boston type keratoprosthesis helps in identifying perioptic melts, also helps in assessing the angle, epithelium covering the front plate, RPM. But in osteokeratoprosthesis and type of keratoprosthesis that we use in dry eye, it does not penetrate the mucosa, so it has got very limited role in these conditions. Glaucoma, again, can be pre-existing, which can result in progression after keratoprosthesis, or can be a new glaucoma that is developing after the implantation of the K-probe. It is practically not seen in osteokeratoprosthesis, that is the de novo or the new glaucoma post-keratoprosthesis, but is not very rare after Boston types. Infection, again, it's a real problem in Boston type keratoprosthesis, especially in our environment. It can be, infection of the graft, which initially can be managed like any graft infection, but then at the earliest sign of, lack of control with our conservative management, they should have a surgery, and we shouldn't wait for it to melt and or result in, irreparable damage before we decide on intervention. Endophthalmitis, again, can be devastating in these conditions. Other, intraocular inflammation, which we see and which is not very rare, is sterile vitiritis, and again is more common with Boston type keratoprosthesis. How we differentiate from infection is that most of the cases are painless, and that causes just a reduction in vision, respond to steroids, and there can be multiple recurrences, which gradually over the period of time can result in permanent reduction in vision. Specific to osteokeratoprosthesis or other type, which is similar to OKP, is mucosal changes, which can be trophic changes, melts with exposure of the lamina, which may be managed with pedicle graft, or many a times we may have to resort to through the lid keratoprosthesis. Laminar resorption in the long run is another issue, but then it is a pretty late complication, and again, very limited options in this condition other than removing the lamina, either go for a new lamina or change the type of keratoprosthesis. So in short, in keratoprosthesis, consider complication as a norm. Okay, almost all of these cases can have problems sometime during the follow-up period, and which makes it important that preoperative assessment of these patients, not just ophthalmologically, but then about their social background and the ability for a lifelong follow-up is mandatory. Thank you.
Thank you very much, Dr. Vinay. A question for you. When would you think of combining K-Pro with a glaucoma drainage device?
Combining is mainly done in Boston type keratoprosthesis. If there is a significant glaucomatous damage, which we could identify prior to doing the procedure, or if the patient has to be on at least 2 drugs to control the pressures prior to K-Pro, it is always better to combine.
Has anyone would suggest doing a repeat K-Pro for any patient?
Yes. Sen, you are,
See, philosophically, K-Pros are like this. It will either come out, or if it stays in the eye, the patient will go blind from glaucoma. So you're stuck between a rock and a hard place. But like Vinay mentioned, the philosophy with K-Pros is that, these are very desperate people with very severe blindness, and we really can't do anything else for them. So we do a K-Pro, we try to have the patient retain the K-Pro and at the same time protect the optic nerve, control the glaucoma. But life for a patient with a K-Pro is from one K-Pro to another K-Pro. It's except for the OKP, that also not always, but in an OKP significantly better than others. But the Boston type 1 is what we commonly use, and there you're basically going from, you can't expect that the patient will have the same K-Pro in their eye for a lifetime. It's very unlikely. The patients who do end up having glaucoma, and you have some of these patients who have wonderfully retained K-Pro but can't see. But typically it's from one K-Pro to another K-Pro.
Yeah.
So repeating K-Pro is quite common. Anybody who's doing K-Pro practice, I think at least 20-30% of their cases are just repeat K-Pros.
Thank you.
Can I
Yes.
ask a question?
Yes, yes.
Sayan and Vinay, so do you like to do a conjunctival flap or Gunderson kind of thing as a primary procedure when you are doing a K-Pro specifically, in cases where it's really bad surface? Because we know it's mainly the epithelium that, causes issues, especially in, first 1 to 2 months time. So do you like to do that?
No, I have done it, Vinay, Vikas. But the problem is that in the cases that you really need it, you don't have enough conjunctiva. That's the problem. So the only case that you can actually do this is in chemical burns. That also, the problem is that these would probably be cases where the conjunctiva is okay. So you can probably even get away with an allosled. You don't even have to do a K-Pro. So it definitely helps, but finding those cases is very difficult. Just like doing allosled in OCP or SJS, to find an SJS or an OCP case that has a wet eye, that has normal eyelids, that has normal closure, it's very difficult. Rarely you will get a patient where you can do that. It's the same with conjunctival flaps. The cases in which you actually need it, you don't even have enough conjunctiva.
Yeah.
Yes, true.
Thank you.
So Vinay, if somebody, a newcomer, has to do K-Pro, which will be the best case to select, and which will be the red flag not to select?
Well, the best case will be for Boston to start out with Boston K-Pros. Okay?
Yeah, Boston. Let's stick to
Yeah.
Boston K-Pro because
Yeah.
only gods can do.
So obviously the bilateral disease, right? Normal lids, deep fornices, normal lid action, wet eye. Okay, total stem cell deficiency because of any reason. Right. These are the cases that
And
can
if
be.
you can,
What do you think about repeat grafts? I thought repeat grafts would be the easiest for a person to start K-Pro.
Yeah, again.
You have multiple 4-5 grafts.
Yeah. Yeah, but then bilateral.
Yeah.
It can be repeat graft, it can be chemical, it can be, any condition which is resulting in bilateral, corneal scarring, which is not amenable to grafting again. But then the rest of the surface should be normal.
sure. So Sayan, any indication if you want to put as in, not the findings, but any pathology which if somebody's first case, like say repeat graft or LSCD, or what would you suggest?
No, definitely if you have a case of a multiple failed graft like Dr. Namrata was suggesting, that's the best case. The only thing is, nowadays for multiple failed grafts, we usually do a DSEC or a DMEC, and that works very well. So it would be a very complicated case of a failed graft where the AC is very shallow and there's pass all around, but the surface is fine. That I think would be the best case to start with, provided you have some glaucoma support. Somebody can put in a valve if required.